Welcome back to Psychiatry Bootcamp. Transplant psychiatry may seem like a topic that is exclusive to CL work, but keep in mind that these patients don't stay in the hospital forever. The principles that we discuss in this episode will be helpful in conceptualizing transplant patients regardless of your treatment setting. My guest today is Dr. Paula Zimbrean, who is a pioneer and authority in the field of transplant psychiatry. In 2022, she published her book, Transplant Psychiatry, a case-based approach to clinical challenges, which I will link in the episode notes. I'm also linking a helpful piece that she wrote for Psychiatric Times for those interested in learning more about this topic. Welcome to Psychiatry Bootcamp, Dr. Paula Zimbrean, and I will ask you to introduce yourself to our audience.
Hello, I'm Paula Zimbrean. I'm a psychiatrist in the CL service at Yale School of Medicine.
And thank you for being generous with your time. I know you're really a pioneer in the field of transplant psychiatry, so we're very excited to have you coming on to teach us about this. Recent author of the 2022 Transplant Psychiatry, a case-based approach to clinical challenges, which I think is beyond a guide, somewhere closer to a textbook. It takes a case-based look at the problems we might encounter when doing transplant psychiatry. Very, very helpful. We'll point our listeners there for further reading. First question for you. Could you tell us about your journey into transplant psychiatry? Like, what initially piqued your interest in transplant psychiatry?
I was a second-year resident when I first heard about this possible career path. And this underlies the importance of networking as early as possible during the training. I was at a women's psychiatry event in New York City, and I heard Sylvia Hoffinger talking about her work with in transplant psychiatry at Columbia. She had just started the liaison with the liver transplant service, and she was so passionate about her work and described so many fascinating questions and situations that she had to participate in and contribute to. So it sounded like just a fascinating field. And later on, forward a few years later, I was in my first year as a faculty at Yale. And I got a call from a social worker that I had worked really well as a fellow, who asked me, "Hey, we're starting a transplant psychiatry service. Would you be interested?" And I said, sign me up. We had no structure for this. We had no understanding of how it would work, no agreements between departments. But we worked through this step by step, and from a moonlighting role became a full position, a full service in about 3 to 4 years.
So that was how it initially evolved for you, was starting out moonlighting and then having a lot of probably high-level conversations about how exactly the contract is going to work, how the coverage is going to work. It evolved quickly for you then into a full-time gig, it sounds like. Thinking more broadly, how has the role of psychiatrists in transplant teams evolved over the past few decades?
I think that's a great question, because the role and the focus of transplant psychiatry has been shifting. Initially, very early in the history of transplantation, psychiatrists were called upon to help patients with what was called transplant psychosis. It was noted that after the surgery, there were a number of patients who would be, probably we would call them as having delirium now. And it was thought that it's some reaction of the body to the graft that involves the brain. Later on, as the immunosuppressants developed, there were more instances of neuropsychiatric side effects of immunosuppression. But then, as the transplantation work became more structured and started having a more organized way of allocating the organs available, the big question that that we're facing. And that was not just for psychiatry only, but for other specialties as well. But the transplant world had a big question: who are the patients that would benefit the most from this intervention? The main resource for this intervention, the availability of graft, was scarce and continues to be. So psychiatry got pulled into the role of risk stratification, identifying patients likely to do well, or ruling out patients who are not likely to do well and benefit from the surgery. Um, and I think in the last decade, what we're seeing is another shift, this time a little bit away from the risk stratification and more towards asking answering the question of what are the psychiatric interventions that would help the patient do well, and how can they be implemented pre or post transplant. So it's less the question of should we offer the surgery, and more is what can we do to help the patient from the psychiatric perspective.
So it started out as just a clinical reality of needing to treat what's right in front of you, seeing a patient with psychosis and saying, boy, I wish I had a psychiatrist here. And then it became just kind of a pragmatic thing, having to deal with this ethical problem of having a limited availability of organs and a lot of patients that need them. And you're saying now the scope has really expanded. How would you describe for me, like at what point in the transplantation process, psychiatry these days with this new shift is involved, should be involved? When is psychiatric consultation most often employed throughout the transplant process now?
There's still not a universal model for transplant psychiatry, and this is the subject of our discussions in our transplant psychiatry special interest group within the Academy of Consultation Psychiatry. Um, there are different models in which transplant psychiatry collaborate with the transplant services, with advantages and disadvantages for each of them. Very likely, the most common scenario where psychiatrists are involved with transplant patients are pre-surgery to comment on the psychiatric comorbidities of the prognosis, and uh, on what are the risks in regard to transplantation. Things like risk of psychiatric decompensation, sometimes risk of self-harm and suicide, risk of non-adherence with treatment, right? That's the biggest fear of all transplant surgeons. Um, we see more and more integrated programs that provide ongoing care, either pre and post transplantation. And there's more and more information emerging about the impact of these programs upon the general outcomes, not just mental health outcomes, but also general outcomes in regards to transplantation.
Starting to realize that not only do we have a role in the pre-transplant evaluation, but with psychiatric care, you're going to have better outcomes across the board, maybe make better use of these organs and increase quality of life for the patients who receive them. I agree with you that I think, and I guess what I mean by that is it's consistent with my experience that sort of the base level of transplant psychiatry is this pre transplant evaluation. When I think about our listeners across the world, a lot of them are operating in community settings with limited resources where they may not have a proactive CL model. May not have the staff that can specialize in transplant psychiatry. And I think that that sort of foundational transplant psychiatry really is the pre-transplant evaluation. Can you tell us more about the pre-transplant evaluation? What is the question that transplant teams are asking of consult psychiatrists when they consult us for a pre-transplant evaluation?
The question, uh, and and in consultation psychiatry, there is the official question for consult, and there is the real question for consult, right? So the official question is risk stratification for transplantation surgery, right? The underlying question is how is this patient gonna be able to participate in the treatment post-transplant? Um, and what role the psychiatric comorbidities will play in this patient's ability to engage in successful treatment. Um, the components of the pre-transplant evaluation are pretty straightforward. So, of course, there's a need for a diagnostic evaluation. There's and this is also a little bit um, similar with what our forensic colleagues do, in the sense that we have to think of the prognosis of the disorder. So not just thinking about what the next step is, but what is the long-term course of this disorder, and how could that interfere with the post-transplant care? For instance, if we have a patient with panic disorder, right? For psychiatry, that is a relatively moderate, not that severe of a disorder. Certainly it's treatable. We have several type of interventions. And, there shouldn't be any concerns about it. But if you have a heart transplant recipient who has untreated panic disorder, who cannot differentiate the chest pain from the anxiety, from the chest pain that accompanies the heart disease, um, could uh, have major implications for that person, because the person will likely seek care for anxiety, seek medical care for anxiety, and will get very intense, sometimes heart biopsies for panic attacks. And because the medical team wants to be very comprehensive and would treat this as a possible symptom of heart disease. So when we do our diagnosis assessment, we want to think a little bit of how is this disorder likely to evolve with time. Um, and we almost always do a neurocognitive screening. It's important. Neurocognitive problems are frequent in the transplant journey, either from the underlying disease, from the medications that are needed, or from some other comorbidities. Um, and when it comes to diagnosis assessment, we also pay attention to addictive disorder. And again, not just the diagnosis per se, but also what stage of the addictive disorder the person in. Is it in full remission? And what are the recovery skills that the person has developed to ensure that maintains abstinence for long term. And there is also an evaluation of what we call capacity, the understanding of the procedure. But again, it's a little beyond just the surgery in itself. Is does the patient understand the challenges of the whole process, which is essentially lifelong? It's a lifelong commitment to an intense relationship with the medical system. And what is the patient understanding of that? What are the uh, strengths, the psychological strengths, and the liabilities that the patient has when it comes to being ready to engage in that relationship?
It's interesting, we talk about the sliding scale of capacity. And when I think about kind of each end of the scale, you could think about, I always use Tylenol for a headache being sort of the lower end of the sliding scale. And I guess I can't think of anything further than a transplant as the most extreme part of the scale, because not only is it this procedure, my current problems, my symptoms, et cetera, but it's also for years down the road. Do I understand the risks and benefits? Can I put it in my own context, et cetera? Because these patients are signing up for decades, sometimes, hopefully decades, of really significant medical care that they're going to need. So that's a really good point about capacity. So you're saying, I want to put a really fine point on this because I think this is the most maybe sensitive area of transplant psychiatry that I have seen. Is the role of a psychiatrist to serve as a gatekeeper or a detective who will weed out candidates who are at risk for poorer outcomes?
I think psychiatrists are very uncomfortable with that role. Um, there are still programs that might designate the psychiatrist in that role, in the sense that they would expect from the psychiatrist uh, a verdict of go or not go. Um, Even with that, uh, there's always in most cases there is the option of a patient being no go for now, but with these particular interventions to become a go. Um, it's important for any psychiatrist who engages in working with transplant service to really clarify how the psychiatric assessment will be integrated in the overall assessment of the patient. Um, One thing that nobody would like to do is to become the gatekeeper for difficult cases, but have nothing to say with other cases. So it's important to um, have a good understanding together with the surgery colleagues and other internal medicine docs who are involved in this, how the assessment will be integrated uh, um, in the overall decision.
Sure. So you have your capacity assessment, you have your diagnostic assessment, your complete social, psychological, family history, et cetera. And then you really are just fitting that into that's one piece of a very complex decision that is being made at a multidisciplinary level.
And with that, I want to throw an idea there that I think it's important to think about. In my career, I've met patients for which, due to their underlying psychiatric conditions, it turned out that a transplantation was not the best option. And in most cases, this decision was made together with the patient, as was by exploring the concerns that the patient had. And I'll give you an example. A patient that has bipolar disorder or had steroid-induced bipolar more than once, with horrible experiences of mixed episodes, like not the fully grandiose euphoric mania, but bad episodes. They might have spent the family's money on it. And I had patients who were so terrified of just the risk of steroid induced manic symptoms that they would prefer to stay on dialysis and not pursue kidney transplantation. This is not a conversation. This is not a decision that one would make lightly based on one meeting only. And patients might change their mind. They might feel more confident after a year or two. But it's a scenario that occurs. Another condition would be patients with severe post-traumatic stress disorder from assault, for which being in the hospital, it's re-traumatizing. And being admitted in the hospital for medical procedures, for exams, all the training hospitals with a lot of people coming in, putting their hands on patients, it would trigger depersonalization, dissociation, severe symptoms, and patients that was just too terrifying as an experience. And they chose a palliative care approach with and gave them years of acceptable quality of life. So we have to think of what is the best scenario for the patient with what we know about psychiatric conditions.
Thank you. That is hard-won clinical wisdom. And thank you for diving into that for me. I'm the clerkship director here, and I gave my just half an hour ago, I was giving my clerkship orientation. And one of the things that I was talking about is how one of my favorite parts about psychiatry is we actually get to spend time with the patients. And listening to you talk about this, it just is very obvious to me that, one interaction might be, you need a kidney. We have a kidney for you. Are you down with that? Cool. Great. You have a kidney, right? And maybe you take 10 minutes to have that conversation. But when you get to know someone over the course of an hour, 2 hours, 3 hours, and you're talking about their values, their quality of life, their longitudinal history with their psychiatric disorder, because you've spent the time and gotten to know the person, you can sort of have these more nuanced questions around what actually are the patient's goals. And are we pursuing my goals as a doctor, which is to get you well and keep you on the planet for longer and improve your quality of life? Or are we pursuing the patient's goals, which might look a little bit differently? Those are wonderful examples to really bring that to life for us. Thank you for that. Psychiatry Bootcamp is brought to you by Simple Practice. Simple Practice has been a great partner for us because, as you know, I find time with the patient to be a therapeutic intervention more than documentation. So Simple Practice makes documentation easy. They have an AI-powered note writing tool integrated within the EHR. So it's a true all-in-one EHR. It's HIPAA compliant, it's high trust compliant, and now it includes AI. What more could you want? Simple Practice saves you time so you can focus on what matters most. They're offering Psychiatry Bootcamp listeners a 30-day free trial for their AI note taker and an exclusive 7-day free trial and 50% off 4 months for Simple Practice EHR. Visit simplepractice.com/bootcamp for this offer. That's simplepractice.com/bootcamp. Psychiatry Bootcamp is brought to you by Beat the Boards. Listen, Beat the Boards is offering us a ridiculous deal. Bootcamp listeners now get free access to over 4,400 exam style questions for USMLE Step 2 and over 4,500 questions for USMLE Step 3. This is not a discount. It's completely free. Don't miss this opportunity. Go to beattheboards.com/bootcamp to get started today. I used Beat the Boards to study for my own board exam, and I found that it made the exam a breeze. It really reflected the real exam. Give it a try. Beattheboards.com/bootcamp. In sticking with this pre-transplant evaluation for a little while, are there any standardized instruments that would be helpful for psychiatrists, for learners to reach for in a consult setting when we are tasked with performing pre-transplant evaluations?
That's a great question because this is such a complex evaluation that includes exploring so many facets of our patients that there has been a need for, can we put a number on it? Like, not just have an impression or a, low, medium, high risk kind of evaluation. But can we put a number? It's all about, measurable outcomes, right? So there have been tremendous efforts to develop structured instruments. There are for to help that transplant psychiatry evaluation. There are three main scales that assess the psychosocial risk pre-transplantation. The most commonly used and translated in many languages is the Stanford Integrated Psychosocial Assessment for Transplantation, developed by our colleagues in Stanford. And there are two other instruments, the Transplant, the Transplant Evaluation Rating Scale and the Psychosocial Assessment of Candidates for Transplantation. This Transplant have been around for a longer time, but they're a little bit simpler and then don't dwell in that many details like the CITA does. The authors and the researchers who have studied this instrument have repeatedly recommended that they are not used alone in clinical decision making. And it's important that they are used in conjunction with a full clinical assessment and also with um, a clear understanding of what the center criteria are for listing in order to maintain equality in terms of access to transplantation for particular center. In addition to these scales, transplant centers often use standardized symptomatic measures for depression, for anxiety, for addictions, for addiction severity. Again, to help inform the overall picture, but not per se as cutoff for moving on with transplant or not moving on to transplant. There are also these symptomatic instruments also help monitor the patient over time. And now they're increasingly used in medical settings, as you know, like primary care, cardiology. So it helps uh, having an understanding of how patient presents across the medical spectrum, and kind of can allow comparing and in certain situations, like in the way we think about post-transplant depression, for instance, the necessity for screening and monitoring. Um, Changes in these scores could trigger an intervention, could trigger an assessment and a more proactive approach to, in particular, depression, because that was our guideline document. But one can think that you can design similar proactive models for other type of psychopathology post-transplant.
Beautiful. So we're talking about that measurement-based care, our screeners, our symptom rating scales, so that we can compare apples to apples. However, you're making a very clear point that these are one piece of the picture. These are one piece of our comprehensive clinical assessment. They can be helpful. We cannot simply give a patient a screener and make a clinical decision based solely on that screener. Appreciate the nuance there. Moving a little bit past the pre-transplant evaluation now, maybe a little bit more into what we can really do to fulfill our role as healers, et cetera. What are the most common stressors that you see for a patient who is awaiting a transplant?
Uh, that's I think that's a great question, because it's important to think of this journey um, as a stressful one. It's not. Oftentimes, our patients feel like, oh, if I'm only on the transplant list, that's the on everything will be okay after. But actually, it's just the beginning of the journey. So the wait list for organ transplants vary significantly in the timing, and uh, there it's marked by coping with a severe medical problem, right? An organ is failing. When somebody has reached this stage, an organ is not working. So there are a lot of medical events, which could include hospitalization, could imply being inactive on the transplant list. And there's a lot of uncertainty about the candidacy in itself, right? Somebody is waiting for a kidney but has an active infection, is becoming inactive. Um, uh, the, the the patient might not know when they get deactivated, if like until that actually occurs. Um, then there is, especially with long waits, there's significant life changes that occur with being very ill. There are shifts in the role within the family, within the primary support group. People might have to give up their professional identities. Um, Children grow; they don't need them anymore. There's a lot of loss that occurs, and sometimes it's processed, sometimes it's not, because patient has to deal with life-threatening medical emergency all the time. There's not much focus on the psychological piece. Um, there could be medications that impact the psychological well-being. There could be confusion and neurocognitive decline that occurs as a part of the disease. And there are the uncertainties about the process. Like, you don't know. You have no control over when it's going to happen. Um, sometimes people get called in, and then the organs proves to be no benefit upon a more closer evaluation. It's extremely intense emotionally. So those are some of the things that occur pre-transplant. Then post-transplant, there is the euphoria of finally it happened. Then the complications, the adverse medical events that might happen or not. And then at some point comes the realization that life will not be normal. There would be some aspects of normal life, the quality of life improves, but there will always be the risk of losing a graft, the necessity of medical treatment. It's always going to be there with the limitation that it brings.
What a long journey with a lot of ups and downs along the road, a lot of waiting, a tremendous amount of uncertainty. You sort of are breaking this down into different phases for us, right? You have the pre-transplant, you have the perioperative recovery where they might be really medically sick. And then you mentioned that euphoria right after the transplant. They've been waiting for so long, the uncertainty, the stress, and there might be this expectation of catharsis that this is all done. But then maybe that quickly gives way to this sort of maybe final stage of acceptance of my life maybe is not going to look the way it would look for someone who did not have a transplant, or the way that I allowed myself to fantasize about when thinking about life after a transplant, because I just needed to hold on to some hope to keep myself going. You mentioned there the family system, the support system. And when I've kind of been familiarizing myself with some of your work to prepare for this interview, I feel like that's a thread that you weave in a lot of the teaching that I've read that you've done. And I also feel like when you gave examples before, that was some of the best content we've had on the podcast. So I want to ask you for a specific example of a case where you, as a transplant psychiatrist, have been able to bring healing, not just to the patient, but to their support system as well.
That's one of the most satisfying pieces of this work is when you can help the patient along the journey. The one patient comes to mind was this woman in her early 60s who had lithium-induced kidney disease and had a diagnosis of bipolar disorder and needing a kidney transplant. And I remember when she came with her husband to the pre-transplant psychiatric evaluations, and they were extremely nervous, both of them, very, very, very anxious. So we talked, and uh, I pointed out to them, like, you really said, what about this made you so nervous? And in turn, they were um, very open about it. They were afraid that I was gonna say that she's not a good candidate. I'm gonna stop the journey right then and there. Um, and she and what happened is that they had a similar experience many, many years ago with one psychiatrist that they had seen who turned out not to be very, very supportive. So they were kind of anticipating like similar thing. We identified some areas where her treatment could have been um, uh, changed a little bit to help her. She was facing starting dialysis very soon. She had a psychiatrist that known her for many years, and we were able to talk together. And she continued to work with a psychiatrist for next few years, and then she moved towards listing. She was listed for transplantation, and she was very, very stable and insightful. Then she asked to come back with her husband without us needing, like, nobody in the medical team thought it was needed or had any concerns. And it turned out that she was about to start dialysis, and she was very anxious, nervous about that. And she wanted to speak with me like somebody who's familiar with this, to kind of learn more and think what to expect, and oversee or look again at her medication, see if there are any changes then. So we did that. Then after the transplant, I saw her in the hospital. She had some steroid-induced mood changes. We worked on that. She went back to see her psychiatrist in the community after discharge. And then her psychiatrist retired. And she couldn't connect with community treaters. Like they felt that she's too complicated. So she asked me to take over her care. And that was several years of journey. There were a lot of medical complications, hospitalizations, family very involved, but there were crises. She had inclusive manic episodes. So I was able to help the families through that. And she ended up passing away from medical complications many years after transplant. And family, we met after that. So it was an overall um, a long course where, as a transplant psychiatrist, I was able to help in various ways. So, consultant and a treating psychiatrist. And I think it illustrates nicely the range of interventions we can provide in transplant psychiatry.
Yeah, that's a beautiful story, and I'm just thinking about all the relationships that you have developed with patients who are quite medically ill and all of the different facets that come with that. I'm also thinking that it's intuitive to me that a transplant psychiatrist would be sort of the furthest on the knife's edge between medicine and psychiatry, because what could be more medical than taking out an organ and putting in a new one? But you've given several examples here of where you can use your medical training, your medical background to just sort of set expectations for the patient, to kind of manage those expectations, let them know what's coming down the road, spend the time to explain these really complicated and scary things in a language that the patient will be able to understand and in a way that is in their particular concept, in their particular context. And I think that liaison role is what I'm really hearing from you, is kind of bridging that gap between all of these medical things that are going on, the psychiatric problems that the patient is facing, and being able to walk with them through this really very long journey. Okay, so in thinking about the immediate post-transplantation phase, and actually you've mentioned steroid-induced mood changes several times, which we see a lot on every consultation liaison service. What psychiatric problems do you most often deal with immediately post-transplantation?
In addition to the steroid induced mood changes, there's often delirium, and there are neuropsychiatric toxicity from other immunosuppressive agents, um, which can be very challenging because uh, they're extremely troublesome to the patient and family. But on the other hand, those medications are necessary, actually are essential for survival of the graft. And the choice of immunosuppressants for post-transplant phase, it remains relatively limited. There are not too many of them that are available. So we often have to help the patients cope with that. And if the symptoms are mild, help them be able to find their quality of life despite the symptoms. Another condition that we see is the post-traumatic stress type of presentations. And we call it PTSST, post-traumatic stress symptoms, transplant related. So between the ICU stay and the transplant surgery and this understanding, a lot of, especially patients with liver failure or heart failure, they're dying when they get the transplant, right? They're in a situation where their life is hanging on a thread. And uh, it's the definition of trauma, right?
Right.
And then the post-transplant course between ICU still, but occasionally need for surgical reintervention. Um, that can also not rarely trigger symptoms of post-traumatic stress, which can range from full dissociation, flashbacks to more like milder symptoms like like nightmares that become manifesting only sometimes much later, like months later. People become avoidant or they're extremely nervous when they come to the transplant center for follow-ups because there's always bad news. That's what the patients feel. Every time I come here, it's bad news. Um, so that is something, and I think we as psychiatrists we have to actively ask because it's hard for the patients to admit that the memories of them are when everybody's so excited, like, oh yeah, you have
Exactly.
for them. So that is something that we do have to actively and repeatedly ask and allow them, create an environment where it's safe for them to talk about that.
And I think what you're implying is you don't find what you don't look for, right? It's like, why is this patient struggling? Or why is this patient not showing up to these really important clinic visits? Or why is this patient so worked up every time they. And if you're not thinking this way, if you're not looking for these things, maybe screening for these things, but following with someone who's going to ask you about these things, you would have a lot of complications in treatment, just even just in terms of being able to adhere to the medical recommendations, and you'd have no idea why.
Yeah, exactly.
Any others in the immediate post-transplant phase, or should we move on to the years down the road?
What we are seeing more and more often these days are the persistent cognitive struggles. We expect that patients would go back to their cognitive baseline after the acute phase of recovery, of medical recovery. And what we're seeing is that there's the subtle, less fluid cognitive challenges persist for longer. And they're very frustrating to patients. Um, as again, their expectations of full recovery are not always met. I think we still have a long way to fully understand what is the underlying mechanism of that. Um, how much the medications are playing a role, how much is the organ disease, like a history of hepatic encephalopathy, if that is playing a role. We still need to understand more about those.
Beautiful. Yeah. Because I guess in theory, right? Maybe if you're just thinking like you are a human DSM, it's a delirium, the delirium resolves, we're back to normal. But clinically speaking, and I think you're saying this is especially true of transplant patients, but I think it's true of a lot of patients who are relatively frail that it is delirium. And yet I think just kind of seeing things clinically and clinical common sense is that not all patients do return to that prior cognitive baseline. And in post organ transplantation patients, maybe especially so. Thinking more longer term, how does solid organ transplantation affect someone's psychological and emotional life years down the road?
That's a great question because patients survive longer with transplants, right? So we're seeing patients like 20 years after, 10 years after. And yes, how can we help them? So in addition to the underlying psychiatric comorbidities, which do not go away with transplant, right? They're still there. I think the major psychological thing, especially in the first few years post transplant, is coping with a loss. Uh, it's not loss of life, that's great, but there were a lot of losses that occurred as patients were dealing with a long chronic illness. Um, and that is probably the most common theme and the negotiation that they have to do with recovering some of that loss or accepting some of that and building new activities, new relationships, new sources of self-esteem and psychological growth in this life post transplant. We're learning more about specific psychiatric conditions and when post transplant they're more likely to occur. For instance, depression seems to be more common later on, like more than 2 years after transplant, we start seeing the depression more. Addictions. Sometimes patients are maintaining abstinence for a year or two. They'll have a lot of medical visits, which kind of continue to motivate the maintaining the abstinence. But then there's this ongoing strive and desire for normal life, and might start with one glass of wine here and there, but a person with addiction might not be able to handle that, and it becomes more of a severe condition. Another theme post-transplant is relationship with the donor. And with living donor, in those cases, that could be not necessarily a source of stress, but a source of questions and effort to navigate. There's no right or wrong, right? What's the right amount of closeness to your donor that you should have? But there can be on the recipient mind. It can be something that really it's really something that they're preoccupied about. If the organ came from a deceased donor, there could be a concern about expressing gratitude. What's the right way of doing that towards the family, or versus if they don't feel that they can do that, they can be feelings of guilt or the survivor guilt that sometimes they are. Again, these are concerns that patients might not bring up spontaneously, and we have to create the space for them and be there for them and encourage them to bring it up, so we can assist when needed.
Just hearing you talk about that piece about the relationship with the living donor, I feel like that's a question that I have not really considered much. I mean, you wouldn't consider it unless you find yourself in that situation. And you wouldn't find yourself in that situation unless you have been alive over the last 2 to 3 decades, right? After all of the years of human evolution, this is a brand new problem. And I'm feeling myself get worked up even just hearing about it because it just sounds so emotionally complicated. And I think you're really displaying for us how helpful it would be to have an expert walk alongside you who has seen this process before, who has had some experience navigating this experience, who is emotionally attuned to you, who knows you, who cares about you, to help you through that process. Because, yeah, that sounds really complicated. The other thing that I'm thinking about is just how much the entire process from pre transplantation to long term post transplantation is just riddled with grief, right? There are so many different periods throughout the transplantation process that grieving needs to occur, right? And we're almost, I'm almost thinking about this final stage of acceptance at the end, but really you're getting to acceptance amongst every loss along the way. When you initially go into end organ failure and need a transplant, there's grief there. When you realize that you can't just take an organ out and put it in, and 24 hours later, your life is back to normal, right? There's a lot of grief associated with that. And I think it's just, you must really be an expert in grief counseling to work with these patients. Thinking now more about the field more broadly as we kind of wrap up here, what do you see as the future for transplant psychiatry? How can the field evolve to better support patients?
I'm convinced we're going to see more and more long-term integration of psychiatry with transplant. Um, I think it's going to be acknowledged and accepted that there's more to do than one risk evaluation. I do think that we will see more and more transplant recipients or organ donors in general psychiatric practices, um, because they will be medically stable and doing well and live longer. Research-wise, I hope we will be able to learn from this process things that about the mechanism of disease and the course of disease that would inform the psychiatric practice in general, not just transplant psychiatry. I think that if we could understand what are the mechanisms that lead to the cognitive problems post-transplant, um, what helps people stay abstinent post-transplant because the rate of relapse is much less. Um, I think that uh, there are a lot of things that we could actually inform the world of psychiatry beyond just the transplantation. Um, so those are my hopes for transplant psychiatry.
I love it. And what resources would you recommend for a medical student, for a learner who wants to involve themselves more deeply in transplant psychiatry, other than your 2022 casebook, which, again, having paged through it, I think if there's a problem in transplant psychiatry, you did a really good job finding a case that illustrates it and then talking through, even like with diagrams and very clear summaries, kind of how to handle each of these individual problems. What resources would you recommend for these people?
Um, as a student and even a resident, I think it's important to really understand the the processes of both psychiatry and transplantation. Uh, Transplant psychiatry, I went into this thinking it's going to be a very narrow niche with a very, focused knowledge base, only to realize that I was very naive. And actually, you have to know all psychiatry because um, you really have to understand or know where to find the answers for questions that pertain to all kind of psychiatric disease prognosis, setting, treatments. And at the same time, it's really important in order to do this work meaningfully is to understand what transplant involves. I'm not saying, I mean, as a student, probably one would want to go to the OR. I'm not saying that psychiatrists have to be in OR for all the patients and know all the techniques, but know the main phases of the treatment, understand the medical risks, understand. So at the end of the day, we know what the patients are facing. So we can integrate that with the mental health care and be able to help the patient progress through this journey.
And any final thoughts for our listeners?
Transplant psychiatry is a truly multidisciplinary um, uh, work. It illustrates well working with many medical specialties, but also other disciplines like social work, nutrition, um, and it, it's an extremely rewarding field to be in. So I would encourage young folks to explore it.
Wonderful. And I think to your point, maybe these are probably some of the sickest patients, thinking medically, certainly, and with a very unique set of psychiatric problems. So hopefully they will continue to explore the field. Thank you so much for spending this hour with me this morning. I know you are a busy person, and you were certainly at the top of my list for a guest on this podcast. So hopefully a lot of people can have their eyes open to transplant psychiatry, and they will know where to find your resources if it piques their interest.
Thank you for having me, and thank you for bringing this topic on your series.
Thank you
Appreciate
so
it.
much. Thanks for listening to this episode of Psychiatry Bootcamp. If you enjoyed the podcast, please take a minute to leave a review on Apple Podcasts or a rating on Apple or Spotify. You can reach me at psychiatrybootcamppodcast@gmail.com. Find me on TikTok or Instagram at Psych Bootcamp. Our theme music is by Cave Radio. Special thanks to Matthew Braddock for production support. The opinions shared on this podcast do not reflect the opinion of any institution, including host or guest employers or podcast partners. This podcast is not intended to be used as medical advice or in any legal proceedings whatsoever, including to establish a standard of care. This podcast is intended only as a supplement to a complete, accredited psychiatry residency and is grossly inadequate to rely on for medical decision-making. It is intended to entertain and inform. You should always rely on your own clinical judgment when making medical decisions and contact your physician for medical advice. This is a Human Content production. Hey everyone, thanks for watching. If you enjoyed the show, please remember to subscribe to the channel. If you'd like more episodes, you can click right here. I'd love to connect with you more, and I'm looking forward to talking to you next.